as president, I'm really impressed how cardiothoracic surgery has responded and reacted to the pandemic, and welcome you to tonight's education and discussion about what's happened, how we did it, and how we might go forward from it. So thank you, Bhuvana, for organising it.
Thank you, Mr. Kendall. Thank you, everyone. Good evening. Thanks for coming on Saturday evening. The first speaker is Dr. Iqbal Toor. He is a consultant cardiologist at Wythenshawe Hospital. Iqbal, are you happy to start?
Yeah, I'm happy to start.
Okay.
Thanks very much. So first of all, I'd like to thank Bhuvana and the organisers for the opportunity to take part in this webinar. The title of my talk is Acute Coronary Syndrome and Cardiology Workload during the first wave of the COVID-19 pandemic. Next slide, please. So the focus of my talk will be on how the COVID-19 pandemic has impacted on acute coronary syndrome patients, including STEMI and non-STEMI patients, and also I'll give a general overview of cardiology services during the pandemic. Next slide, please. So over the years, there's been a huge emphasis on door-to-balloon time in the treatment of patients with ST elevation MI, but during the COVID-19 pandemic, this has been de-emphasized to a certain degree. Planning for the COVID-19 pandemic has involved devising protocols to look after three broad categories of ACS patients. These are the COVID-19 test negative, positive patients, those with suspected COVID-19 symptoms, and the COVID-19 test negative patients. This principle has been developed in Manchester into a blue, yellow, and green traffic light symptoms for ACS patients. During the early phase of the pandemic, testing wasn't widely available, and so we relied more on symptoms to stratify our patients. So for the blue patients, which are test positive for COVID-19, we take a much more of a measured approach and have a very high threshold before bringing them to the lab for primary PCI. In the yellow category, which are the STEMI patients with potential COVID-19 symptoms, we assess them first whilst they're in the back of the ambulance, and then if they meet criteria, they're brought to the cath lab with the cath lab staff wearing full personal protective equipment, including N95 masks. And in the green category, which are the STEMI patients without COVID-19 symptoms, we are able to take them straight to the cath lab, and the staff are wearing standard PPE with a minimum of a surgical face mask. Essentially, the non-STEMI patients have to be green, which is COVID test negative, before we undertake an angiogram, unless they have intractable chest pain or are hemodynamically unstable. Generally, as a rule, we've tried to reduce the transferring of patients with COVID-19 test positive between hospitals in order to reduce transmission. Next slide, please. The initial reports from China were that there was a sharp decline in patients presenting with acute coronary syndrome. These are bar graphs from data from Italy from a 1 week period in the beginning of March in 2019, the year before, and this year during the height of the pandemic in Italy. And they show a similar experience to what we saw in South Manchester, which was approximately a 50% reduction in ACS admissions during the peak of the pandemic. Of these, there was a decline, more so in the non-STEMI patients than the ST elevation MI patients. As you can see, the data from Italy shows a 65% decline in a non-STEMI presentation and a 27% decline in the STEMI presentations. Our experience in South Manchester was that STEMI patients were sicker, and this was most likely due to patients presenting later. The data from Italy also shows a significant increase in mortality in patients with ST elevation MI. We would normally expect a 4% mortality in our STEMI cohort, whereas this increased to approximately 14% in this Italian registry, and this was sort of similar to what we saw at Wythenshawe. Next slide, please. In light of the lower numbers of patients presenting with ACS, the next question is, what's happening to the ACS patients that are not coming to hospital? This is data from northern Italy, and the blue hash line on both of the graphs is the average across the 4 regions from which the data has been collected. What they did was plot over the course of 2 months the incidence of COVID-19, which is in the top graph, and in the graph below shows the excess incidence of cardiac arrests in comparison to the previous year. So they found that out-of-hospital cardiac arrests arose by as much as 50% during the COVID-19 surge. So this suggests that patients were staying at home, essentially because they're afraid to come to hospital and literally dying at home. So this underlines that we need to be advocates for our patients to come to A&E when they're acutely unwell during this COVID-19 pandemic. Next slide, please. During the peak of the pandemic, there were significant pressures on ITU resources, which meant that the capacity to offer surgical coronary revascularization was significantly reduced. Professor Gerslick at the University of Leicester had the foresight to set up the REVAS registry, which collected data on COVID-negative patients who would have ordinarily undergone surgical revascularization, but were instead treated with PCI. They collected data on 171 patients who had an average syntax score of 27.8, which indicates a high complexity of coronary disease. Indeed, 45% of these patients underwent PCI, had left main and multivessel disease, and 41% had multivessel disease without left main involvement. So far, we only have data on in-hospital outcomes, and they are similar to what we would expect with surgical revascularization. Over the course of the coming years, we'll learn more about the long-term outcomes for these patients. Next slide, please. At the beginning of the pandemic, there were a number of hypotheses put forward on how COVID-19 or SARS-CoV-2 may affect the heart. Next slide, please. This was especially as the virus uses the ACE2 receptor to enter cells, and ACE2 is abundant on cardiac myocytes. So cardiologists were anticipating potentially having to deal with acute cardiac complications in COVID-19 patients. However, direct cardiac toxicity of the virus has not been that common. Next slide, please. However, we are seeing cardiac injury in COVID-19 patients, possibly from a mismatch in coronary blood supply to the cardiac demand, but we suspect the majority of cardiac injury in these COVID-19 patients is mediated through non-coronary mechanisms. Next slide, please. Also, in COVID-19 patients, we see an exaggerated inflammatory response from mass cytokine storm in severe and critically ill COVID-19 patients, and this has been implicated in these patients developing biventricular failure. Next slide, please. Furthermore, the pro-inflammatory state in COVID-19 patients makes them more pro-thrombotic, and they are more likely to have large pulmonary emboli, which can manifest as a right heart failure. Next slide, please. In our experience so far, COVID-19 patients presenting with ACS hasn't occurred that frequently, and also arrhythmias aren't that common and mainly occur in the critically ill COVID-19 patients. And interestingly, there have been no published reports of autopsy-proven myocarditis directly due to COVID-19, but we are seeing inflammatory cell infiltration of the myocardium leading to heart failure. Next slide, please. And so biventricular failure due to cytokine storm following COVID-19 in the severe to critically ill patients can lead to biventricular failure, and which we are seeing in our ICU patients. And also pulmonary emboli causing RV dysfunction is also a feature we're seeing in the severe and critically ill COVID-19 patients. Next slide, please. Next again. So hopefully it's playing well for you. But we're also seeing that in patients that are becoming more difficult to ventilate, the increased positive pressures required increase RV afterload and result in acute right heart failure. This is an echo for a COVID-19 patient that the anaesthetist was struggling to ventilate and also was becoming hypertensive. In the image on the left-hand side of your screen, you can see the right ventricle in the top is the top left hand chamber. You can see that the right ventricle is dilated and almost the same size as the left ventricle. Next slide, please. A common question as cardiologists we're being asked is for which patients should cardiac biomarkers and echoes be requested in order to look for the cardiovascular effects of COVID-19. We're finding that troponin elevation is a frequent phenomenon in COVID-19. However, the small troponin rises usually are associated with a completely normal echo. So this is a bar graph showing that only a small number of all comers with COVID-19 have a large troponin rise, whereas the vast majority of patients, which are on the left-hand side, have only a small troponin or a normal troponin. Next slide, please. These are the survival curves for COVID-19 patients stratified by admission troponin, and the blue line represents the group with the highest troponins, and unsurprisingly, they have the worst outcome. So the current evidence suggests that there may be value in performing troponins in severely and critically ill patients on mechanical ventilation. So in the UK, we use high sensitivity troponin assays, so those with troponins in the thousands are probably the ones which may benefit from an echo, whereas the vast majority of our COVID-19 patients don't need cardiac investigations. Next slide, please. In terms of the elective cardiology workload, from my perspective at Wythenshawe Hospital, we had an 8-week period from the start of April where cardiac imaging was cut down to and restricted only to those who urgently needed it, in terms of those patients with symptomatic valvular heart disease. Also, we cancelled potential aerosol generating procedures such as TOEs and stress echocardiograms. However, we were able to run at least 2 labs during the COVID-19 period. We were using guidelines produced by our cardiology subspecialty bodies to identify those patients which required urgent procedures. So this will be mainly coronary and heart valve patients with symptoms on minimal exertion or at rest, and those with symptomatic heart block or needing secondary prevention ICDs. Next slide, please. So with regard to outpatient clinics at Wythenshawe, we switched to telephone clinics as soon as NHS guidelines were issued to stop routine face-to-face consultations. Though we were still able to offer face-to-face consultations where this was clinically essential, and this allowed our heart failure service to be maintained. Our pacemaker clinics were run using remote checks from home, or using drive-through clinics where remote checks were performed with patients seated in their car. By moving to virtual clinics, we were able to keep on top of our outpatient clinic workload. Next slide, please. Our experience with ACS patients highlighted the need to be advocates for cardiac patients. There rightly was a strong emphasis from central government on protecting the NHS, but this was at the expense of the public not seeking help. So to address this, we collaborated with our cardiology colleagues at Matron Infirmary to produce a video encouraging the public to seek help if they are worried about any new symptoms. Next slide, please. So finally, the COVID-19 pandemic has been a huge learning experience. To successfully negotiate the pandemic, we focused on protecting our workforce by developing COVID-19 protocols and rehearsing them, by creating a safe hospital environment. This will hopefully increase the confidence of the public to seek help if they're worried about their symptoms. And as a positive that we can take from the COVID-19 pandemic, this has allowed us to accelerate the move to more innovative ways for delivering outpatient clinics. However, our experience with ACS patients has been that there is a real danger to patients with cardiac symptoms not seeking help. And so we need to address this through public engagement. Well, thank you for your help, and I'll be happy to take any questions at the end of the session.
Thank you so much, Iqbal. It's very interesting and very comprehensive topic. And thank you so much. And we will wait for the question at the end. Mr. Kendall?
Bhuvaneswari, thank you. I think Tony Walker may be Mr. Tony Walker at Blackpool. He's a cardiothoracic surgeon at Blackpool. He may be committed to being in emergency surgery tonight, operating on a patient, but I believe that he's very kindly recorded his presentation for tonight, and look forward to his presentation now. He's a long-standing colleague at Blackpool who is a very successful unit with a great team, and I've seen that unit flourish over the years to provide great service to the Northwest. Tony Walker.
Hello and good evening, and well, many thanks for joining us on a Saturday evening. My name's Tony Walker. I'm a cardiac surgeon at the Lancashire Cardiac Centre in Blackpool, and I'm very grateful to Bhuvaneswari and the Society for the opportunity to share with you some of my thoughts, observations and opinions and perspectives of what's been happening in cardiac surgery during the COVID pandemic. Or perhaps in a nutshell, what happened when Tony met the virus. It's perhaps important for me to point out that the things we're going to talk about are entirely my own thoughts and opinions. They're not in any way necessarily representative of the wider Cardiothoracic Society or community, or indeed surgeons in general. And I felt it necessary to point that out, because one thing that has become apparent during recent events is that everybody seems to have an opinion and to become some sort of political expert. So, well, I hope this gives you plenty to think about. So it's actually quite amazing what this tiny, well, to be honest, as far as I understand it, in viral terms, this is actually quite a big problem, but it's amazing what it's managed to achieve over such a small period of time. It seems to have turned every single one of us into some sort of political pundit. I don't know of anybody who doesn't have an opinion as to how much better they could have done with managing things. We have all become pseudo-experts in public health. We know about social isolation, we know about droplet size and modes of transmission, we know about, dare I even mention, PPE and what PPE to wear in different circumstances. I presume you do know about that, although to be honest, after 5-6 months, and particularly now that the rules seem to be being relaxed, it's getting even more confusing once again. Perhaps as a result of the daily briefing, we've all become obsessed, not that as cardiac surgeons we weren't anyway, with big data, statistics, and everybody now seems to be an expert on mortality rates. And indeed, I've got 1 or 2 graphs that I'll show you later on in this presentation that show how obsessed everybody has become with that aspect of it. And there's been lots of other examples of skills and abilities people have learned during lockdown to help them cope with this huge change in their daily routine. So one of the extra roles that I have is as speciality editor for the Cardiothoracic Surgery at the Royal College of Surgeons. I would never claim to be some great academic, but I am quite interested in writing and scientific writing and editing. And if you put in a search term into PubMed and look in the top left-hand corner of the screen, you get a count of the number of publications that have appeared per year for that search term. So in the mid-80s, for example, a new kid on the block appeared. This was quite a trendy illness. It had a very striking public health campaign. It had a great big slate gravestone that descended onto the screen and had no less than John Hurt telling you how to be careful and how to avoid HIV. You can see here how there was a gradual increase throughout the mid-80s, perhaps into the 1990s, of increases in publication, documenting the progress of the disease, defining the disease progress. Then as treatment started to emerge, enthusiasm and publication increased further, peaking at about 17,500 publications per year in the early 2000s. At about the same time, in the early 2000s, there was another emerging problem, named after the famous singer. MERS made a fundamental mistake. By including a geographical locator within its name, it excluded most of the world from having any interest in reading or writing about it at all, until most recently, where due to its similarity with the next kid coming along, its enthusiasm seemed to pick up. And here it is, coronavirus. It's been around for a long time. It's nothing new. As Donald himself said, it is barely more than a common cold. But in 2020, it went crazy. There have been, again, approaching 18,000 publications so far this year. In the first 6 months of 2020, 18,000. That's more in 6 months than HIV had at the height of its popularity. And by comparison, here we have something a bit closer to home. Ischemic heart disease and its treatment, coronary artery bypass grafts. This has been a slow burner, slow and steady over time. New techniques, new imaging, and as bits have evolved over that time, there have been increase in publications. But what you can't see on the graph is the y-axis, and there has never been more than 1,000 publications per year about coronary artery surgery. Any of you who have published anything will know what an absolute ache and pain it can be. And that's been recognised in no less than Nature, who have shown that it consistently takes over 100 days from submission of a manuscript until its acceptance, and this has not changed over time. The digital revolution has made no difference to that in one bit. It is consistently on or around or even over 100 days. There has been some improvement and a steady decline in the time it takes from acceptance to then your work appearing within the manuscript itself, but that still runs at around 20 to 30 days. So being generous, that is about 4 months for any piece of work to be accepted and to appear in print, and doesn't take account of all the ethical applications, grant applications, data collection, data analysis, all the work that comes in before you actually publish the work subsequently. So how on earth, and I guess I'm urging for a bit of caution, how on earth have we approached 18,000 publications within 6 months for a disease that was virtually unheard of before Christmas? I guess what I'm saying, and I hate to mention him again, but maybe Donald's right, that there's a lot of fake news out there, and even some quite reputable journals seem so desperate to get things out and get things published relating to coronavirus that perhaps shortcuts are being taken, the peer review process and editing is possibly, dare I say, not quite as rigorous as it would normally be. So, back to my original brief regarding the surgical perspectives of coronavirus, and this painting by Escher is all about perspective, and with the eye of faith there are 3 main staircases, 3 main areas that I want to concentrate on, and they are pre, peri and post. You can think of that as pre-operative, peri-operative, post-operative. You can think of that as pre-COVID, peri-COVID and post-COVID. To be honest, it's all going to be a little bit of a hodgepodge, and I'm not here to tell you how it is. What I'm going to do is using examples from my own department, from my own practice, to try and illustrate what we've experienced, perhaps what we could learn, and perhaps most importantly, what we can take forward with us into the post-COVID world to move on safely from here. Because there's no doubt, you've heard it from everywhere, from everyone, things are very different. Whether they're going to stay different, I don't know, but let's have a look where we're up to at the minute. So, in the middle of March, in preparation for what was coming, Sir Simon Stevens, the Chief Executive of the NHS no less, wrote to all the regional executives, the executives of all the trusts in the country, advising them that to ensure capacity within the system was maintained, they were to start winding down all elective activity. Although it wasn't said in as many words, the NHS was effectively closing down. Now, I've had a look, and the NHS performs 10 million operations per year. So 10 million patients were about to have their operations that might have been planned for quite some time put on hold. Of those 10 million procedures, approximately 18 to 20% are emergencies. Now, he said in his letter that emergency work, cancer work would have continued, they weren't to be affected. So approaching 2 million procedures were still to go ahead. In cardiac surgery, we do between 40,000 operations per year, and in Blackpool, I know that approximately 30% of what we do is on urgent inpatients, emergencies, and a few salvage operations. But these are the people who are in hospital waiting for their operations, and they weren't to be affected by Sir Simon Stevens' announcement. So that was quite a significant statement. To protect the NHS was going to have a huge impact. So what we've shown you here is our waiting list from May 2019 to June this year. And as you can see, throughout the middle to end of last year, we worked really hard. There were things in place to try and reduce our waiting list. What we've got on the top are the cardiac cases who were waiting, and the orange line at the bottom is thoracic cases, which has been fairly static. And then obviously in February, March 2020, elective activity was stopped and the waiting list has started to creep up again. What I think is particularly pertinent and important point here is that it took us 8 months to reduce the waiting list, but you can see it's gone back up to certainly where it was, if not higher, within half that time. Part of the reason for that is, I don't know about you, but I have not missed a single clinic. As soon as the news broke that we were to cut down face-to-face and to close the NHS and our practices, I started doing my clinics over the telephone. We now have access to attend anywhere and other online media for which we can keep our clinic activity running. And it's not all bad news from the virus. Things have changed, things have progressed. And I have no doubt the attempts to do things online and over the telephone were bubbling away in the background before the pandemic arrived. And there's no doubt that the speed of change has certainly improved greatly. This map shows a very rough representation of our geographical area for which we cover in Blackpool. We cover a huge area, lots of it quite rural, up into Cumbria, across towards Blackburn, and down towards, although not necessarily including Wigan, Manchester. And it's a huge, very diverse, as I say, from rural communities to some of the most deprived in the country. So asking patients to come to us is no mean feat. There's huge distances to be travelled, and by some of possibly the most poor and patients with great limitation. So I used to do a clinic in Blackburn, in fact I still do, but there's been a very enthusiastic response to me actually ringing people up or offering to see them camera-based web systems so that nobody's having to travel. And I'm sure the Trust similarly are quite grateful that they're no longer having to pay my travel expenses. Before we move on to one of the more obvious perioperative changes that COVID's brought, it's just a thought regarding clinics. In cardiothoracic surgery, we have some of the most robust scoring systems and risk assessment tools in modern medicine. Yet when you talk to somebody on the phone or even over a camera link, really all you have to go on are the bare facts. You have an angiogram, an echo, and whatever that patient is telling you. And from that, you then come up with a conclusion about the risks and benefits of the surgical procedure. It's been quite interesting for me, just paring everything back to those basic facts and making a decision based purely on that. I think it'll be quite interesting. Obviously, I'm going to meet these people probably at pre-assessment clinic, and it'll be interesting to see whether there's then any backpedaling from what I might have told them on the phone about how beneficial an operation will be when I then actually see how frail or otherwise some of these people might be. So I guess with that, it's watch this space. So anyway, continuing with the perioperative phase, I'm not actually convinced that much has changed. Aside from wearing a bit of fancy or strange-looking equipment, the basic procedures are the same. In order to help our general intensivist and COVID specialist colleagues, because we've got a nice fancy unit, it was felt most appropriate that yes, we would stop all the elective activity as dictated from above, but that we would also move out our intensive care. It became a COVID intensive care, and our theatres were converted to have intensive care capacity. We weren't left without a home. We were rehoused in the ophthalmic department. They had 2 operating theatres, and post-operatively our patients went to what used to be general intensive care and general HDU, but this had a huge impact on our activity. So this graph shows our activity data for the last 5 years. And whilst it's been split into 6-month periods, so the beginning of the year, January to June, and then July to December for each since 2015, and as you can see, no surprise for the first period of 2020, it's perhaps not quite like falling off a cliff, but it's certainly sliding down a rather precipitous, unfooted scree slope, which as surgeons is disappointing because, as I say, we do like to operate and that's what we get paid to do. As we talked about a little bit earlier, Sir Simon Stevens had cancelled all elective work, and that's what we see here on the blue line, so same time periods. The blue line is the percentage of our work done electively, and the orange line is the percentage done as emergency or in-house urgent work. And as you can see, for those time periods, it's usually batted along at a fairly constant 70-30 split until, again, the first period of this year, where it's come down to, I think it's about 58 and 42, which was a little bit of a surprise, but I think that's because I'm looking at it in 6 months blocks. So there was January, February, where we did still do elective work, because certainly from April onwards, for 3 months, we did nothing but in-house urgent cases. And I'd be interested to know what surgeons from other places in the country have done, and perhaps more importantly, it'd be important to see how this split then starts to spread out again when elective work resumes. Aside from the silly attire, there were a few other changes to help our colleagues with some of the skills we perhaps have. We volunteered to look after HDU and general intensive care. Because of the stresses and changing environment, we felt that it was safe or safer to only do 1 case per day. And there was a general feeling that cases were taking much longer and that we wouldn't actually physically be able to fit in 2 cardiac cases in one day. So what this graph here, for the same time period, shows the cross-clamp and bypass times for procedures. Obviously blue is the slightly longer bypass and red is the cross-clamp times, and as you can see, there is no significant difference. In fact, over the time period since 2017, I guess as case complexity has increased, those times have gradually increased, but you can see most recently in the beginning of 2020, associated with the coronavirus, cross-clamp and bypass times have actually decreased slightly. Neither of this is very dirty science. In fact, it's barely science at all, but there's certainly no statistical difference. So certainly surgically, I don't think operations are taking any longer. A final thought that we try to pride ourselves on in Blackpool is training, and so here, what I've shown here is the percentage of cases actually completed. So this is entire case, not parts of case, so there are lots of other variables that might influence this, but this is the actual full cases done by non-consultant grades, and you can see that on average this runs around the 15% of cases are done in their entirety by non-consultant grades. We had a bit of a problem in 2017, but this may actually also represent, I suspect more likely, the stage of training that the staff, the trainees we had at that time were. And in 2020, again, there's been a bit of a hit, no doubt about it, but perhaps not that devastating from the Blackpool average as one might expect. If I'm being completely honest, I suspect most people have found this whole situation, yes, stressful, but also very frustrating. I particularly remember one patient having a teleconsultation with her, and she was in tears. She'd been referred for mitral valve surgery, was only in her early 50s, extremely symptomatic to the point where she was deteriorating and having to spend her nights sat in a chair to get anything like any degree of sleep. I'd given her appropriate advice. We'd tried to change her medication to optimise things, and we were at the point where I was advising her to come into hospital. She was absolutely terrified about doing that, and in her own words she said and felt that nobody was looking out for her, and it was all just about coronavirus. So I've shown you a few graphs about what was happening with Blackpool cardiothoracic activity. Well, here's what's actually happening in the wider Blackpool region in terms of coronavirus. The blue line is the total number of positive tests in the area. You can see there's a very interesting, almost diacrotic notch, sort of 4/5 of the way up that graph, the opposite of what happened with the national data, where they suddenly started including deaths from care homes. For some reason, we actually had a few tests that were suddenly not positive, and the count seemed to go backwards. The orange line is the number of cases, so of those positive cases, the number of cases being treated in hospital, which has never exceeded 100, which is way off the modelling that was produced by Imperial College, and which I believe the government based their predictions on, where we were warned that we should be expecting over 200 ventilated patients. And in fact, you can barely see at the bottom the grey line that looks fairly static on this scale, ITU admissions. So if we zoom into that in a little bit more detail, this is the daily rolling average for our hospital of coronavirus cases needing critical care management, and you can see that we're now, well, we've never exceeded an average of 12 patients in critical care, not the 200 predicted, and we're now getting back to what we were almost at the middle of March when we took us the epidemic starting. Don't get me wrong, there's absolutely nothing wrong with prior preparation and planning, and it is absolutely right to be prepared and to have things in place. People, as you know, people have died of this, and it has been devastating across the country and the wider world. However, what has frustrated me, being completely honest, is an apparent lack of people being unwilling to look at the evidence and look at the data and to then implement that in better preparation for what might come next. I often laugh and hesitate to get her involved, but my mother-in-law insists when you ask her what the weather's like, she gets out her phone and she looks at her weather app rather than just looking out the window, and I sometimes wonder that people have relied too much on predictive modelling, and they've not actually looked at the data of what has actually happened with coronavirus, certainly in the local areas, because thankfully, it's good to be prepared, but thankfully we have not been affected as much as elsewhere, and I worry that our cardiac patients have been affected a lot more than they needed to be as a result of that. So, as we start to bring this to a close, I'm sure you all recognise this. I think at the time this was a very, well, I'm no marketing man, but I think this was a very effective, very clear message. And I think the point of protecting the NHS was achieved admirably. I'm less sure when you saw pictures of the police and the army maintaining the stay-at-home message in Spain and in Italy. I'm less sure how effective the nation was at staying home, and I'm very unsure, clearly, as to the effectiveness of this saving lives, but there is no doubt capacity was maintained within the NHS. I think there were two main factors leading to this. The first is that the general public were so scared by this message and scared of the virus that we know footfall through the NHS, through A&E, we know from cardiology colleagues that presentations with acute MIs absolutely went through the floor, and there was no presentation and activity, and our referral base, certainly urgently, was minimised. So capacity was maintained because people simply didn't turn up unless they absolutely had to. And I think a second great factor for maintaining capacity was the gatekeepers of critical care. Intensivists and anaesthetists helped greatly by maintaining capacity within the system, by carefully controlling access to this valuable resource. Conversations were had with patients about what was important and where they might want to spend what could turn out to be the last days of their lives away from their family and friends, and they are conversations that I do not have a problem with. I'm not sure that in the height of an epidemic is the time necessarily to be having them, but I have no doubt that these two factors played a huge role in protecting and maintaining capacity within the NHS, aside from the fact that the actual denominator was increased enormously with the production of what turned out to be hardly used Nightingale hospitals. So, thank you very much. I hope that's given you a small and certainly incomplete insight into one cardiac surgeon's opinions, thoughts and approach and experiences during the pandemic. Things are slowly getting back to normal, whatever normal might be, and hopefully we're in a slightly better place in that some things have come along that will make my team and my patients' lives a bit easier. There are undoubtedly new collaborations taking place that I think will enhance things further. And in many ways, perhaps we should be hoping that things don't simply return back to normal. So thank you very much. Thanks for your time. And I look forward to receiving any thoughts or questions from you. Many thanks. Cheerio.
Okay. So, Mr. Kendall, would you like to do yours?
I'll be fine, Bhuvan. Yes, it'll be fine. Okay, good evening, everyone. I'd like to talk to you about the effect of the COVID-19 pandemic on cardiothoracic surgery in the United Kingdom. This is based on my experience as the incoming president of the SCTS. I think we've all got our own experiences and our own knowledge, and I'm very happy to be corrected on anything I say this evening. So I'm not saying what I say is the truth, but it's an opinion on what I've witnessed. I think back in March that we were all very in our readiness for the pandemic. I witnessed a lot of denial around me in the health sector and in the public. I saw the pandemic being trivialized by various colleagues and in the media, etc. But at the same time, there was fear. There was significant preparation in the health service, and I think a few of us were lucky enough to undergo significant training. I work in Middlesbrough, and it was my view that it was our capital city, London, that bore the brunt of the infection first. And I can't imagine what it was like working in London when the infection was spreading quickly and the admissions to our hospitals were going up very rapidly. And at that time, I think most of us witnessed patients having major cardiac and thoracic surgery who were unlucky enough to contract COVID and develop a bad reaction and have very poor outcomes from their surgery. And this added to our fear and apprehension of what was coming. Clearly, an awful virus if you suffered its worst effects. On a national scale, I was very impressed how cardiothoracic colleagues stepped forward and volunteered to help in the care of patients with COVID disease. And all of us got redeployed from our normal roles. I witnessed trainees around our country, trainee surgeons giving up their training to go and work on COVID wards or go and work in ITU or HDU and put their own health at risk enduring the uncomfortable working conditions looking after these patients. I'm aware, and I saw specialist nurses going back into the ITU, going back into the wards, going back into the COVID wards to treat patients. And again, it was commendable to them that their own health on the line to look after these patients. On a national level, of course, cardiac surgery uses level 3 care, and our level 3 facilities were either designated to become general ITU facilities or to actually help with COVID patients. And again, we saw our own staff, colleagues, nurses, anaesthetists, intensivists, all putting themselves to that cause. Consultant surgeons also were helping, some of them as ITU registrars, some as medical registrars on the medical wards. And I think obviously my own colleague, Joel Dunning, was high profile in taking on the role of an ITU nurse as well. Not only was it uncomfortable in wearing the PPE in these environments, but we went out of our comfort zone in how the established practices were changed. And for instance, no longer was level 3 a 1-to-1 nurse ratio, going up to 3-to-1 or even 6-to-1 in some institutions. I witnessed all the theatres and the anaesthetic rooms being prepared to be extra level 3 care. And we saw the Nightingale hospitals built in incredibly quick time in case there was overwhelming need for ventilated patients and intensive care patients. It was very difficult at the start. There was difficulty with triaging patients. And of course, it also involved very, very difficult conversations with patients about their wishes and about their wishes to have their care escalated. And I can't imagine what it was like for people used to seeing cardiothoracic patients do well following surgery, suddenly going into a situation where the outlook was looking very, very bleak. In retrospect, our country will have to look back at sending patients who may well have been positive with COVID back into care homes. And it would look like there will be inquiries into this decision making. But I've already spoken to many colleagues who felt at the time it was the right thing to do because we were so scared of the overwhelming demand on our NHS for relatively younger patients that it seemed at the time appropriate to send these patients back to the care homes. But this will be, I think, a recurrent conscience for our nation of the decisions that were made at that time. During the lockdown, we had a celebration of the VE Day, and I think we could all make comparisons to how the population at that time had coped with the war and the Blitz, and how we were coping with the pandemic. And in particular, I felt that the comparison of how the media supported the country during the Second World War compared to the performance of the media through the pandemic was a stark contrast. I think the media at first were almost, dare I say, thriving on the story. And they dwelt on the awful fear of NHS workers dying. They dwelt on the fear of all ages dying and people without health conditions, the fear of lack of PPE. I observed that testing became politicized. And also there was a lack of coherent reporting. You would hope that there was a standard amount of data to be reported, but it seemed that our media could interpret the data how they wished to give the story that they wanted. And I felt that added to the stress of the situation when actually we could have done with responsible media, giving as true a picture as they possibly could agree on to help us collectively work together to a more constructive end. Overall, though, I thought the response of the health service and the response of cardiothoracic surgery was extremely good. It was very fortunate that most centres didn't have to overflow into theatres and anaesthetic rooms, although some metropolises like Birmingham were really struggling and were overflowing. During the pandemic, cardiothoracic surgery had to be triaged and performed very carefully with full PPE. And we were contacting our patients at home to see if they were deteriorating. And lung cancer surgery was being moved into the independent sector, or with small tumours actually being redirected to other therapy, such as stereotactic radiotherapy. Iqbal's already mentioned how the incidence of acute heart disease, coronary syndromes dropped dramatically. The rate of TAVIs went down 50%. The rate of PCI overall went down 50%. There was an 80% reduction in cardiac surgery alone. So huge reduction. Helen Munday is going to talk later this evening. But London really showed the way of how to reorganise a health service for a pandemic. And for cardiothoracic surgery, the St Bart's Hospital and the Harefield Hospital agreed that they would become the specialist centres for cardiothoracic surgery, and the other level 3 facilities and theatres used in our specialty were designated to look after the COVID surge. So overall, I think there was so much well done in the face of an unprecedented event, and there was an extraordinary positive response to the lockdown. There were no police or army on the streets, and it was remarkable how the population responded in a way that will probably never be seen again. There were some things I saw in the NHS that didn't do ourselves the justice that we should have done. I think in my own hospital and in all the media reports that I saw NHS staff not keeping a distance from each other. And when the public were being told to keep their distance, it did not do our cause much good to be seen so shoulder to shoulder, particularly on the Thursday night claps. We operated on a COVID patient in our own hospital and went to the COVID theatre. The staff were very apprehensive. We were all stood socially distanced waiting for the brief. And I was shocked when our lead general anaesthetist walked into theatre in his normal clothes with a wristwatch on and his laptop in his hand. And it was one example for me where people were not taking the risk of cross-infection seriously. And I also heard of handovers in COVID ITUs where staff were gathering in small rooms with no PPE, no social distance, and these were in COVID units. And I think it's taken quite a few weeks for us to learn the importance of social distancing in NHS, and obviously now we have the use of face masks as well. So where are we now? I think we're seeing that the number of cases and the number of deaths are really coming down in France, Spain, Italy, and the UK. And let's hope that there is no second spike, because that would have a major impact on the healthcare of everyone else. I think we now need to think how we can get back to treating patients in a more normal way. We need help from Public Health England to reduce the level of PPE in a proportionate way. And we need the help of the Royal College of Anaesthetists and Intensive Care to do proportionate protection in the intensive care, the level 3, level 2, which will free up these areas to treat cardiac and thoracic patients. We're certainly already using less PPE in theatres for the surgical staff and for the runners. And we're trying to go against regular testing for staff because that would seem not to have a positive effect for staff morale, nor on the level of care that we can give. There is some pressure now to look after the waiting lists that are developing, and we are considering whether PCI or TAVI or radiotherapy is more appropriate for some patients when we're reviewing our waiting lists. But I would hope that rather than giving less efficacious treatments to these patients, that actually we can increase our throughput through our theatres and our intensive cares. There are some real positives that have emerged from this terrible event, and Iqbal's already alluded to them. Firstly, at a national level, we've seen data sharing, which has been unique. There were too many people with data sets who were protecting them before the pandemic. And the pandemic caused everyone to show how you can share data to help patient care and assess the national need in such a more timely way. Virtual consultations are now here to stay, and we're all appreciating that even new patients as well as follow-up patients can be reviewed without the patient having to get up, find a car parking space in the hospital, queue in a waiting room, etc., etc. It's much more convenient for them to have a virtual consultation. We're learning virtual meetings in our units, national level, regional level. It's much easier than getting in the car and driving to a meeting or getting on the train. And education, we're really learning how we can educate each other with virtual platforms such as tonight's webinar. and it will probably transform a lot of national society meetings. That the didactic work can be done on virtual platforms, but the business meetings and the social aspects can be done in a briefer meeting, but with the same outcome. Finally, I'd just like to mention the other thing is virtual MDTs. There has been some difficulty getting adequate representation at MDTs, and particularly between district general hospitals and the hubs. And already we are seeing that colleagues from the district general hospitals can join the mitral MDTs or the aortic MDTs or the revasc MDTs. And there is a real sense of bringing that team together for the patient benefit, making more timely decisions, sharing investigations within networks to make the patient care more timely and better planned. This is real potential for care in the country. We're also going to be better prepared for the next pandemic. Hopefully it won't be in our lifetime, but we will be better prepared for it and will respond quicker to it. So I'm impressed by the incredible flexibility of our specialty in this pandemic, not only on the resources of the beds and the theatres that we have, but the extraordinary flexibility and dedication of all the staff. The Association of Cardiothoracic Anaesthetists have to be particularly commended because they have gone in at the level 3, level 2 arena and used their skills so well. And I'm particularly impressed with the allied health professionals because they've gone back into the front line and done a great job. So Bhuvana, thank you very much for giving me this opportunity to speak tonight. And as you can tell, I'm very proud of how cardiothoracic surgery in the UK has responded to this pandemic. Thank you.
Thank you so much. Mr. Kendall, would you like to introduce Helen, please?
Helen Munday is the lead allied health professional for our society. She's given 4 years of her life to looking after the allied health professionals for our society, while working hard at Papworth Hospital, preparing for their move from the Papworth site to the Addenbrooke site, and now she's matron in cardiothoracic care at St Bartholomew's. Exceptional leader, and we've been very lucky to have her support the society. Helen.
Thank you very much. Can you hear me?
Yes.
Lovely. Thank you very much. Thank you, Bhuvana, very much for this opportunity to present this evening. And Simon, thank you very much for that warm introduction. So I've been asked to, and good evening, everybody. Sorry, I have to get used to not being able to see everyone. So good evening to all you in the virtual world there. So Bhuvana has asked me to talk this evening about cardiac surgery workload and staff redeployment during the COVID pandemic at St Bartholomew's Hospital. And before I start my talk, I must say a very huge thank you to Mr. Steve Edmondson and Mr. Martin Yates, who have very kindly and generously given me permission to share some of their slides that they've put together and are constantly changing as the situation evolves around the Pan-London emergency cardiac surgery PLEX service that was put in place that Simon alluded to in his talk. So I must acknowledge their slides in half of my talk. So thank you very much. Next slide, please. So, as has already been mentioned, in response to the COVID pandemic, the elective cardiac surgery was reduced in all centres, and it was the decision was made to have 2 centres which would be purely designated to providing emergency cardiac surgery across London. And those 2 hospitals, as has been mentioned, were St Bartholomew's Hospital and Harefield Hospital. And that came into effect on the 23rd of March. Next slide, please. So this is a slide that we're sadly all too familiar with now, but clearly illustrates the peak, which really hit us in London very much around the Easter weekend. I remember that Easter weekend very, very clearly, as even though we've been having lots of activity going on in terms of how we were going to redeploy staff, how we were going to increase ICU capacity. That Easter weekend, it really did sort of feel as if it had escalated quite significantly. Next slide, please. So this illustrates the cardiac surgical centres in London pre-pandemic. And the next slide, Bhavana, please, will show how those were reduced to the two centres of Bart's and Harefield. Next slide, please. So in total, now these figures are sort of as correct as they can be to date, but the Plex service is still running, and so there might be some discrepancy, but so far the number of referrals has been 647, and Bart's had referrals from 42 different hospitals, and this slide is just to show where some of those referrals were associated, where the London hospitals were associated with. And overall, Harefield and Bart's did a similar number of surgeries. Next slide, please. So initially, there was a huge spike at the beginning when, which was a combination of all the in-house cases that were referred, and then it sort of plateaued out a little bit with a couple of peaks in referrals which came after 2 bank holiday weekends, but this was over a 15-week period. So the initial surge was mopping up the patients that were waiting for the surgery already in hospital. Next slide, please. So from the 23rd of March, when the Plex service started, St Bartholomew's had referrals of 336 patients for surgery, and Harefield 344 cases in a similar period. So as you can see, quite evenly matched in terms of numbers. Next slide, please, Bhavana. And of those referred, there were 67 patients who were not considered suitable for patients, and those were not considered suitable for surgery. And they were divided into the 3 groups there for medical management. Some, it was felt that their surgery could actually wait, and they were their surgery could be deferred. And 10 were referred for cardiology percutaneous treatment. Next slide, please. So possibly one of amongst one of the biggest challenges has been trying to manage and contain this within our hospitals. I'm sure I'm not going to be saying anything anything different to what people have experienced in their own sites, but as a centre offering emergency cardiac surgery, we obviously wanted to try and maintain absolute thorough screening and cohorting patients safely, and managing the different areas as safely as we possibly could. Next slide, please. So for theatre precautions and for the ward areas, actually, we're very fortunate at Bart's in that we have 2 quite separate intensive care level 3 areas. So we could physically separate patients quite effectively by having a positive area on one floor, COVID positive area on one floor, and keeping the first floor, which is the other area for level 3 patients, as clean and COVID free as possible for all the emergency cardiac surgery that was coming in. There was a dedicated theatre for patients who were unknown, and to be honest, most patients were treated as if we didn't know when they were admitted, and all operations are performed with theatre staff in full PPE. and patients were looked after in ICU with all the staff wearing full PPE, which went for both areas, both the COVID area and what we were maintaining as a non-COVID area, but there was still that slight uncertainty. And keeping staff in designated areas, limiting staff movement, and of course, like everywhere else, we had no visiting policy, which was implemented straight away, which of course also brought its challenges in terms of the concern and the fear that families, friends, relatives had at home. So again, and in line, I think, with a lot of other centres, we very soon instigated an inquiry hub, which we still have ongoing, and actually proved very successful, and I think really helped to support families who were concerned about their loved ones. Next slide, please. So our screening protocol for cardiac surgery, we started an enhanced screening protocol at the end of March, where patients were swabbed before they came to us. We would, if they were found to be positive, then there wouldn't be a transfer. They would be swabbed again when they were admitted to St Bartholomew's, along with blood tests. And at that time, we were also doing CT scans within 48 hours of surgery. And the other tests that we have been doing, but again, there has been some change recently, was a deep tracheal swab was being taken once patients were intubated, because there was concern about the accuracy of nose and throat swabs. Not all, I have to say, not all staff were very happy about doing these tracheal swabs, because there was concern that it was putting the staff at risk, and so there has been some discussion around that. But generally, we try to get tracheal swabs on all patients. Next slide, please. So this is this illustrates the swabs that were being done on my wards during this time, and before sort of that final week in March, between the 23rd of March and the 27th of March, we began to see more and more patients tested, whereby by the end of March, all patients were being tested that were coming into the hospital. Prior to that, as we all know, testing was sort of quite hit and miss, but as I say, from now we've had all patients tested before they come in or as they come in. Next slide, please. This suggests that we didn't have any positive swabs or positive patients post-operatively. We did actually have one patient in this period who tested, it was a late positive, so had been negative pre-operatively and came back positive post-op, but actually that patient went home well. So generally the pre-op results have been pretty reliable. Next slide, please. So, as I say, over time, we've seen more and more patients tested for COVID, and anyone who was positive, found to be positive on admission, were immediately moved to our dedicated COVID wards and into isolation. And that also was, I mean, I'll go on to talk about redeployment of staff, but that was also a time of great uncertainty and fear, I think, for the staff, because at that time patients were coming in, and we didn't, there was a lot of uncertainty about their COVID status, and I think staff felt at that time particularly vulnerable on the wards. So I think with our screening protocol where it is now, we've certainly managed to reduce or if not eliminate, the number of patients that have tested positive or the risk of becoming positive in the post-operative period. Next slide, please. So as we all know, the guidance around COVID and what we should be doing, whilst it's not changing daily, as we saw in, during the height of the pandemic, there's still constant review about what we should be doing, and constantly looking at what is manageable and what is going to be safe for our staff and our patients. So we have seen a reduction in the screening protocol, and this is the SCTS published guidance supporting that the notion that a CT scan now did not need to be done unless they were for in-house urgent cases or any other kind of suspicion. But our elective admissions now, they are expected to have isolated at home for 14 days prior to surgery, have no symptoms of COVID, which is discussed at a telephone consultation prior to admission. And then patients are admitted 2 days ahead of surgery in time to get the COVID swab result back. Next slide, please. So staff redeployment. As I said at the beginning, I'm not sure that there's anything that we experienced at Bart's which will have been any different to colleagues around the country, but for every individual, it was a unique experience. And decisions had to be made very quickly. Training had to be done very quickly. Induction to ICU was very fast. It was a model of ICU nursing that I don't think any of us recognised, task orientated, the stretched staffing models that Simon has already mentioned, and the daily communications that seem to change every day. And the sum of all of those things meant that it was a massive, massive challenge for everybody involved. And I think, Simon has already said just how amazing everybody was, and I think that's something that we have all reflected on. But it certainly was a very challenging time, and I think we are still seeing for some staff almost a post-traumatic response that they've had as a result of it. So next slide, please. So to say what Bart was asked to do in terms of our staff redeployment, and increasing our capacity in ICU. So initially we were asked to increase to 158 beds, which was just a bit more than half of what we are used to having. And then possibly with a plan to go up to 171 if needed at some scale, at some date. Obviously the scale of this, we didn't know how it was going to pan out. Fortunately, as we all know, the Nightingale Hospital at Excel was never needed to anything like the full capacity that it was originally planned for. Thank goodness. And we found within our own hospital that the number of beds we thought we were going to need wasn't actually ever needed. So we were scaled down to having 53 beds on our 6th floor, which was for COVID positive patients and patients requiring ECMO, plus 42 beds on our 1st floor, which were designated purely for cardiac surgery. We had 227 nurses who went through rapid training for ICU, as in a 2 to 3 hour classroom induction, very, very fast. And then of those 227, 135 nurses were redeployed to ICU, along with many other members of the MDT, as Simon has already mentioned. Next slide, please. So what is next? So St Bartholomew's Hospital is one of 5 hospitals in Bart's Health. We have the Royal London Hospital, Whipps Cross, Newham, and Mile End Hospital and St Bartholomew's, who all form part of Bart's Health. St Bartholomew's, as a specialist tertiary centre, does not have an A&E. We did not see anything like the kind of pressure that our colleagues at the Royal London Hospital saw with their A&E, and I have to take this opportunity for a big shout out to them, because their respiratory wards were absolutely overflowing. Their A&E was bursting, and as you may have seen on the press, their ICU has grown enormously to cope with future demands. So that gives us at Bart's a bit of a luxury, really, because we are aiming to stay as a green site and as COVID-free as possible, so that we can continue to provide cardiac and thoracic surgery to our patients in a safe, COVID-free hospital. There will be undoubtedly some positive patients who will come into the hospital possibly for ECMO, through the heart attack centre, where we're not able to screen, and so we have our unknown patients. But essentially, St Bartholomew's will be barring those patients, a COVID-free hospital. There's a lot of work going on looking after our staff, health and well-being, and I think, yes, there have been lots of positives that have come out of this awful situation, and I think the way staff have been looked after through this has been hugely appreciated, and we need those kind of things to continue, not necessarily the donations and the free food and things like that, but actually just looking after each other and just being considerate and kind to each other, and recognizing when colleagues are struggling. There's been lots of engagement and communication learning from our senior managers, from our executive team, who are very keen to work with the staff to find out what will help and how we can support staff. Even things like availability of a comfortable rest area, of a coffee room, having a locker, things that are important to staff that actually previously has been quite difficult to get. Those are things that we're starting to see, and that's that's very, very welcome. And of course, managing the risk and looking after our staff, doing these risk assessments, which some have felt have come a little bit late, but we are where we are, and we are trying certainly to make sure that we're in a much better position should the next wave come along, which I hope it doesn't, but I think we will be in a better position if it does. Next slide, please. So to conclude, we did manage to maintain cardiac surgery through the pandemic. I think fortunately the numbers were not as large perhaps as might have been anticipated, but I think that was, as was mentioned previously, people's fear of coming into hospital, and clearly there is a concern about patients waiting at home, not listening to their bodies, not listening to their symptoms, and seeking help when they need it. So we are seeing surgery increase now, and hopefully we are restoring public confidence in our hospitals to reassure people that it is safe and it's the right thing to do to come to hospital. With strict isolation, screening, multiple bed moves and logistical nightmares sometimes, we have been able to maintain patient safety. And as I say, it's has all been made possible by phenomenal hard work that I never thought at this stage in my career I'd be seeing something like this. But working in the NHS, it never ever ceases to amaze me, and this has been no different. So thank you all out there. Thank you for everything that you've been doing, you are doing, and we will all continue to do. Thank you very much.
Thank you, Helen. That was excellent. Thank you very much. Very enjoyable, very informative. I just enjoyed Helen's talk because she's gone much more into the detail, and it's a further reminder of what we've gone through, and it's easy to deal with the day-to-day challenges that we have now and looking forward. But if you just pause to reflect on what we've been through and what's happened, it is quite remarkable. So much change in such a short space of time. Okay, so everyone, please, if you've got a question, you can put it on the chat, and happy to answer the chat, or unmute your microphone and please ask us directly. That's a good question. Future screening for cardiac patients? Helen, what are your thoughts? You touched on it in your presentation. I've got my thoughts as well.
It is a very good question. Thank you. I think as we hear more about this, and I think as public confidence is restored, I'm hopeful that there will be a lot more screening and preoperative isolation of people before they come into hospital that will enable us to deliver a safe service without having people in hospital for the periods of time that we have seen waiting to have treatment, because I think we've got to balance it between what is safe for patients and what is deliverable, what is actually manageable. And I'm still seeing patients that have swabs and then the results don't come back, and then we lose theatre slots, and it's just not a very it's not going to be an efficient, sustainable service if we don't have if we don't improve on this. So I think there's got to be an element of public responsibility of how well people look after themselves and isolate themselves before they come in, so that hopefully if we need to get screening results back much quicker, and we need people to be honest about any symptoms they might have. Otherwise, it's just not going to be manageable.
I'd agree. I think things have moved fast. We've gone from CT scans, swabs, isolation, etc. We've now abandoned CT scan. We've abandoned chest X-ray. We've gone down to one swab because it's 97% reproducible. And I think it will depend on the prevalence in the community, and it will depend on the prevalence in your locality as well. I suspect screening will get less and less as we get more confident. So we'll see how it goes. So some really good questions coming in here. What did I say? They've gone out of my side here. Hang on. The operative mortality for cardiac cases, if they're positive. Helen, I think it was about a 10 to 20% mortality if you were positive at the time of your surgery. Bart's had the best experience, or not the best experience, should I say, the worst experience of this. Was that your understanding, Helen?
Yes, I think it was. I think I don't know the exact numbers, but I think that certainly there was a reluctance to operate on anyone who was COVID positive because of the outcome. So those that were operated on, without looking at the specific details, I imagine that they were pretty high risk beforehand.
Yeah, indeed. That's right, because we were just doing emergencies as well. So as you say, they were high risk anyway. Indeed. Edward Turner's asked, how large are the current waiting lists and how do we propose to increase activity to address this? Well, I think as you've seen, the activity in cardiology went right down as well. So the number of diagnostic tests going on and the number of acute presentations went right down. So the waiting lists have actually remained remarkably static. But the biggest limiting factor now is using our theatres effectively. So if we can start inducing anaesthetic in the anaesthetic room again and getting 2 patients done a day, because if you have to induce in theatre, it's really quite tough to do 2 cases in a day. And the other thing is we need our level 3 facilities back with proportionate PPE to protect patients and staff, but not make it so cumbersome that it's difficult to use the facility. And as Helen said, I think you can't underestimate the impact on the ITU staff, doctors, nurses. There will be a degree of post-traumatic relapse from what they've gone through. And so on the one hand, you want to drive the programs back up, but on the other hand, I think we've got to be really sympathetic to how the staff feel. Bhuvana, Helen, anything to add to that? Iqbal, if you're there, anything to add?
No, nothing to add. So the question for Iqbal is, under investigations for the effect of COVID-19 on the heart other than troponin?
So in terms of other biomarkers that are under investigation, troponin's been the main one that people have been focusing on. In terms of, so we've got groups in Edinburgh and also in New York who are looking at BNP and the other inflammatory markers such as IL-6 as well. But we're at the very early stage of sort of doing these registry studies. But I think sort of troponin itself is probably just a surrogate marker of the severity of the systemic illness, rather than sort of a particular mechanism in terms of understanding why someone is having sort of direct cardiac effect of COVID-19 on the heart. So I suspect sort of ultimately it'll be inflammatory markers such as IL-6 or routine CRP, which will give us a better understanding of which are the higher risk patients who end up on ITU and end up sort of towards the severe or critical end of the spectrum of the illness.
Okay, John Basford's asked about the pressure on the NHS to use TAVI or PCI to increase throughput. That is true. There is some pressure. There is clearly some political concern about the waiting lists, not just in cardiothoracic surgery, but orthopedics, in ophthalmology, etc., etc. And I hope, as you heard in my talk, we are driving that it's much better that we increase our activity safely than it is to offer patients suboptimal patients. So for lung cancer, we'd prefer that patients still have their lung cancer resected and not have stereotactic radiotherapy if that's the evidence for their best treatment. If the evidence is best that they have a surgical AVR, then that's what we're going to push for and protect surgical practice. So we need the anaesthetist, the intensivist, we need Public Health England to follow that agenda. Helen, what's it like in Barts? Are you getting pressure in Barts to divert patients to TAVI and PCI?
Not for some, for sure. I don't know that it's any more pressure than it's maybe just considered a bit more, but certainly I think those that have gone for that treatment option, actually it's been a good call.
And Iqbal, what's your impression in Wythenshawe? Do you feel that there's pressure on the waiting list there?
Yeah, so we initially, in the first 2 weeks or so of April, we had those discussions with our surgeons where the surgeon would come up and say, can you offer an alternative to surgery? But now I think sort of we've got protocols in place of how to get our urgent surgical patients in, and it's more sort of, and also we've got the similar model to London where we have a green site at the Liverpool Heart Centre as well. So there are options available in terms of if someone needs an operation, they can get an operation. So I think we're back to where we were before in terms of making the right decision based on the complexity of coronary disease rather than the availability of resources.
Iqbal, there's two more questions for you here. One is, what's the effect on patients with cardiac conditions due to COVID and the ways of management? So I suppose that goes with your presentation, doesn't it? Is what is the link between COVID and increasing your acute coronary events and etc. I think that follows on with as COVID-19 increases thromboembolic events, is there any data showing percentage of ACS in COVID-positive patients previously with no cardiac disease?
I don't think we've actually seen sort of embolic events as such. I've had a couple of cases where I've sort of worried about sort of whether a young person with infarcts in multiple territories may have had an embolic event, but they've all come back as sort of COVID negative, and the CT tests have been negative as well. So we haven't sort of seen any firm data to support that sort of embolic events leading to ACS, but it's still, the positive, the negative predictive value of a test is also something we have to consider in terms of whether we can make a firm diagnosis whether someone has COVID, and that has implications on the sort of small, lower sort of complications that can occur with COVID.
Thank you, Iqbal. Thank you. And there's a question for Helen there about ODPs working on ITU and whether this increases their ability to apply for roles on level 3.
So I can't comment specifically on ODPs working in ICUs at Bart's because I'm not sure if they were there, but certainly I think the workforce model as a result of this will change hugely, and I think we've seen that that what we need within cardiothoracic care is a workforce that can adapt and have transferable skills in different settings, and I think that's going to be a massive benefit that we take from this. I've seen staff who were who barely set foot in an ICU who now want to go and work there permanently. So that we've lost staff to ICU, and I feel sure that will not just be amongst nursing staff. There'll be other disciplines who will want to work in that kind of environment, and if with the right training, with the right education and training of those skills, then I absolutely don't see why not.
Thanks, Helen. Ivana, anything you want to add to that?
Especially, I can only talk about our hospital. Yes, there are ODPs who have been deployed to ICU and they did an excellent job. And I think this can be a model for us, as I agree with Helen. So transferable skills should be adapted and people can work in all 3 areas in cardiothoracic, especially in cardiothoracic practitioner.
Thank you. There's a nice question here. Most patients on our waiting list are still scared to come to hospital to have cardiac surgery. Can we safely offer cardiac surgery now to our patients? Well, I'll answer this first. I think every patient we've operated on through the pandemic and since the pandemic gives us more experience and more confidence. And it will depend on the prevalence around your hospital and in your region. My impression as president is that we are doing it safely and we are getting better and better at it. And I think also for patients, I think you're seeing friends and colleagues, there is a range of assessment of risk at the moment. Some of us are very scared and we think the threat is very real, and some people are too blasé about it. And somewhere in the middle is probably right. And the patients will feed off our confidence in our service. So it will depend on what their experience of what they're hearing from the media, etc. But also it will depend on what they hear from our secretaries when they're contacted, from the nurses when they meet them, from us as doctors, etc. So I think if you've got a good service, every case you get more confidence. I think you can reassure people that we can do it safely. Helen, Iqbal, anything to add to that? Do you think that's a reasonable summary, or do you think it's riskier than that?
I think that's reasonable. In terms of what we need to do is have pathways where we can sort of reassure patients that they are going to be looked after in areas which are as COVID-free as possible. So most of our cases are elective, so they go home the same day. So it's slightly easier for us in terms of cardiologists to create these pathways where we can have dedicated wards and dedicated staff working in sort of our designated COVID negative ward. So the patients don't have to come in contact with potentially sort of staff who may have worked on a non-COVID ward.
Thank you, Iqbal. Helen, what do you think?
Yeah, I was just going to add that I think another consideration is once we have patients in and they're operated on, we are particularly noticing at the moment the absence of visitors, and where we would have those face-to-face conversations with families, with next of kin before patients are going home when they're visiting. Those are not happening now, and it's not the same when it's over the phone. And I think we've got to be very mindful about how we are safely discharging patients and looking at that whole process of once the patient has gone home, because I think that's a particular concern at the moment, because I can't see visitors coming back into hospitals for some considerable time. And certainly I think we need to review the sort of information we're giving to patients when they go home, again, all to restore confidence when they're talking to friends outside and GPs and things about what the whole hospital experience is like. Because I think at the moment we've got a gap without having those conversations with families.
Thank you, Helen. Thank you. That's really interesting to hear your perspective on that. That's good. So there's the question here: do you think that staff should be tested on a daily basis? I've got a view on this. My understanding of COVID-19 is that you are infectious when you are symptomatic, and that's the most dangerous time. If you are asymptomatic, then has to be quite intimate, the contact, to be infectious. So symptomatic staff should not be in the hospital and they should stay away. And any staff who think they might have symptoms should be tested. But we've talked about the impact on the COVID pandemic on NHS staff. Morale is down at the moment. Having to use PPE is not comfortable. It's not good for retention, recruitment. And I think the testing is a very negative factor. So I personally don't think that routine testing is necessary, but you certainly test if people are suspicious of contact with other infected people or if they've got symptoms. I suspect that's a slightly strong view. I don't know what Helen, Bhuvan, and Iqbal think of that.
I think it's impractical to actually test so regularly because it's quite an invasive test to have done. I've not personally had one done, but colleagues describe, a swab being put up your nose, and sort of it's having that done on a daily or a weekly basis. I think we'd tire of it quite quickly.
Helen, what are your thoughts on testing staff?
I agree completely. I don't think it would be. I don't think it would be manageable. I think the labs would be completely overrun for no value.
Okay, thank you. And then the final question we've got here is: do you know how the COVID-19 pandemic has impacted research into the cardiothoracic field? My comment would be there's been a notable change in that we've suddenly focused on the impact of COVID. A lot of other research trials have gone on hold because it's not possible to recruit patients. And now we're looking to recruit again as we come out of it. So I think in general, research has been put on hold for this time, but has been redirected into the pandemic. Bhuvana, what's your impression of research?
Yeah, as I'm a postdoctoral fellow at University of Manchester, I can't do anything. I have been deployed back to the university and to the clinical, and it is really frustrating because you want to do a postdoc fellowship in 2 years, not in 6 years. But at the end of the day, we have to understand that this is a pandemic and everybody is suffering. So it's for research can take priority later, but the clinical and the staff importance is priority.
Thank you. Any closing comments, Helen, Iqbal? Okay, Bhuvan, I think we'll.
Oh,
I think Helen got some question. Sorry.
no, it wasn't a question. It was just a comment to say I just think this evening has been really informative and really helpful to talk about this and to hear other people's presentations as well. So thank you very much.
Thank you, Helen. Thank you. And Iqbal, thank you very much for giving up your Sunday evening to come and join us tonight. It's been very kind of you. Bhuvan, over to you. I'll leave it to you for closing remarks.
Yeah, thank you so much, everyone. And I'm really sorry that we couldn't able to get Mr. Tony Wakand, but he is operating now, so we can't do anything. And thank you so much for coming. And if you have any questions, please email Mr. Tony Walker at nhs.net. Thank you, Mr. Kendall, for doing this. And Iqbal, thank you so much. Helen, thank you so much.